Okay, well, good morning. We're representing Gardens for Health International. My name is Restina, and these are my colleagues, Natalie Sanfratello, Holly McLellan, and Chelsea Desrochers.
And we want to start off our presentation by asking you to think about the following question. What if doctors prescribe seeds?
Gardens for Health International works to do just that. Established in 2007, Gardens for Health International combats childhood malnutrition by providing agricultural solutions through clinical partnerships. Globally, malnutrition remains a substantial problem, contributing to the deaths of 2.3 million children each year, and perpetuating a cycle of poor health and poverty for millions more. Additionally, maternal undernutrition contributes to 800,000 neonatal deaths annually and is a risk factor for low birth weight. GHI currently works on the clinical and community level by designing and implementing an approach with the main objective to provide long-term solutions to childhood malnutrition, focusing on a shift from conventional acute treatment. Gardens for Health International partners directly with 18 government health centers in Rwanda to integrate agriculture and comprehensive nutrition and health education into the treatment of malnutrition. Clinical staff and partner health centers refer patients diagnosed with malnutrition to the program, and GHI works with each of these patients' caregivers to design and plant a home garden that promotes both crop biodiversity and dietary diversity. Just this past year, the program has expanded from partnering with 8 health centers to 18 health centers in Rwanda, serving 14 health centers in the Musanze district alone. The current program attests to a long-standing presence in Rwanda and a strong supportive relationship with both the national Rwandan government and the local governments in the Musanze district. So we propose an expansion program which targets pregnant mothers in the Musanze district and improves maternal and child nutrition within the critical first 1,000 days. The Musanze district, located in the northern region of Rwanda, 2 out of every 3 children are chronically malnourished. The nutritional status of a woman before and during her pregnancy is critical for healthy pregnancy outcomes, including the nutritional status of the child. Evidence shows that babies born to stunted mothers have a higher incidence of being stunted themselves. Our program provides peer guidance on building kitchen gardens and strengthens existing nutrition education through increased attendance in antenatal and postnatal care visits with follow-up nutrition education in the homes by community health workers. We aim to mobilize the community to reduce barriers to clinic visits while providing tailored training to both community health workers and champion moms, which are leaders in the community. The expansion program will complement the existing Gardens for Health International program by preventing childhood malnutrition before it begins. The median gestational age of a woman's first antenatal care visit in this northern region is 4.5 months, which is well into the 2nd trimester. And a surprising 80% of women do not seek any postnatal care. Earlier antenatal care visits are important for the identification of pregnancy complications such as anemia and gestational diabetes. Women cite multiple barriers to clinic visits, such as lack of childcare for children that they leave at home, and travel distance to the health centers. Targeting pregnant mothers and providing them with the education, tools, and support to improve both their own nutrition and the nutritional status of their children is critical.
So by building off GHI's already successful model, our goal is to eliminate child malnutrition through sustainable agriculture to improve nutrition during the first 1,000 days of life. And we combine this with a clinical program to promote healthy pregnancy. So our first goal is to increase the percent of pregnant mothers' households that have diversified gardens to 100% within 3 years. And then secondly, we look to reduce the median time from last menstrual cycle to the first antenatal care visit from the median of 4.5 months to within the first trimester. And then we want to combine that with increasing the percent of women who actually go to all 4 of their recommended antenatal visits. And then lastly, we seek to increase the percent of new mothers who go to any postnatal care visit from 20% to 50% again in 3 years. So the key players, the field educators, obviously these are the people that are going to be doing all the trainings. And the pregnant moms are our target audience, and we're estimating 5,000 pregnant women in the Masanzi district per year. That comes from a fertility rate of 4.6%. So we're targeting 2,500 women in the first year, 3,500 women in the second year, 5,000 in the third year, and another 5,000 in the fourth and final year. And then the Champion Moms are a group that has sort of grown organically in the community. They do presentations of cooking demonstrations using vegetables from their own gardens. And we just seek to sort of formalize their training to promote antenatal care and nutrition. And again, the community health workers, an important part. We are going to further their education in ANC and PNC promotion and nutrition. And they're also going to play a part in assessing the success of the program by going around and actually counting how many gardens the mothers have in their household and counting the different fruits and vegetables in each garden to give them sort of a proxy on the nutritional intake of that household. And then also the community health workers are going to follow up with nutritional counseling. And then the community, so we want to mobilize the community, as Natalie said, to seek childcare pooling so that mothers don't have to, they can go to their clinic visits without bringing all their children, and also provide resources for transportation because it's a long walk for a lot of people.
So our activities first would be train the field educators so that they are able to go ahead and go into the communities and train both the community health workers and the champion moms. So the community health workers will be trained in nutritional education and support and behavior change, as well as filling in any gaps they may have in their maternal health knowledge. And the champion mothers will be trained in skills for giving demonstration and leadership skills, and they'll also get nutrition education to help support the mothers, and they will also be trained in behavior changes. So the actual education for pregnant women, they'll get nutrition education from the home visits with the community health workers. There'll also be an emphasis on going in to get antenatal and postnatal care, and then they'll also receive the education and support from the champion mothers to help grow their gardens, and the champion mothers can also serve as an example for possible economic mobility within the community, since they've already begun trying to sell seeds and livestock to GHI. Then community mobilization, like we stated before, that will focus first on barriers, one being pooling of resources for transportation for mothers to go in for their antenatal and postnatal care, and then also sharing child care responsibilities so that women don't have to bring their children to the clinic with them or worry about leaving them at home. And then also through sustainability, mobilizing the community, giving and empowering them to tackle the issue of childhood malnutrition on their own, and having members of the community at stakeholder engagement meetings to continue participation and sustainability. And then the clinical support side is community weigh-in events, which will be done by clinicians, and also the antenatal and postnatal care itself. So these are images from current GHI training manuals. This is an image of a complimentary feeding meal with different serving sizes for the age of the child, and the other image is of information on breastfeeding. And this is a diagram on how to plot out a kitchen garden, and the other is of a plate on how to eat a well-balanced and nutritious meal. So for our monitoring and evaluation, we split it up into our 3 objectives. So for nutrition, as was mentioned before, community health workers will be assessing the number of crops in the kitchen gardens of the mothers to assess diversity. And then we'll also be looking at the records for the weigh-in events, both with the measurements of the children, height and weight, and also the number of participants from the community. And then we're also going to be looking at the mother's weight gain during pregnancy and comparing that to the recommended amount. For antenatal care, we'll be looking at the time since last menstrual cycle at the first ANC visit, both on the individual and community level. And then we'll also be looking at overall ANC attendance on the individual and community level. For postnatal care, we'll be looking at the number of participants who have gone to at least 1 postnatal care visit.
So for the budget, for the total of 4 years, it will be implemented at the 14 health centers, and it's a total of $680,000, and it's broken down into personnel and other direct costs. So personnel consisting of the field educators, M&E agents, program manager, M&E manager, as well as drivers, and that comes up to around $380,000. The second biggest cost driver is the livestock and seeds that we'll be giving to the program participants, which will be the pregnant mothers, and that's around $300,000 for all 4 years. So these expenses are not just cost drivers within the budget, but they're also drivers within our program and investments, as you can see in the photos. So for sustainability, many of us in the NGO world, when we think of sustainability, what is sustainability? What does it look like? Does it mean financial sustainability or sustainability within the community? And here at GHI, we think that sustainability looks like this for the future generations of the people within the community, and that entails 100% community ownership and little dependence on foreign aid and support from the NGO itself, as well as improving health outcomes through sustainable agriculture. In the program that we designed, we integrated sustainability within all of the activities in our program, all included in all of the 4 years. So what that includes is starting off with this happening through the creation of the kitchen gardens. So that's providing a sustainable solution to malnutrition through allowing for continued harvest of seeds throughout the 4 seasons. Secondly, the relationships that will form between the champion mothers and the pregnant mothers through a shared knowledge and also a shared resources of what they grow in their gardens. Also through the scaling down of incentives in the 4th year of the program for the pregnant mothers. That's part of our exit strategy for sustainability. And also through the strategic partnerships that will be developed through the stakeholder engagement and community mobilization. So here it will be important that the champion mothers get to voice their own opinion during the stakeholder meetings and have a face in the community. Overall, it's important to always ask the right questions, spend time in the field, and get to know the needs and wants of the communities, but also, is this actually feasible? At Gardens for Health International, we have invested ourselves in the community since 2007 and have formed relationships within the community as well as strong government partnerships. We have found the first generation of community champions and positive deviants within the community, and we will use them as the main focus in our community-centered approach.
So, nice job. And actually, I don't know why I'm going first if this one's about food. this is your area. So, very nice job presenting this, and this is really such a cool idea. So I'm going to just start out doing both observations and questions. I think it's always nice, and this goes for every group, is a little bit telling how the organization started, especially if there's a personal component to it, like it was somebody studying agriculture and then had traveled. So, I just think that's always a nice start. I do think that the first picture that was put up felt a little, you need to tell a personal story about malnourished children and really what the impact of that is. And although you said it, the emotional impact of malnourished children and cognitive development and the implications, you know, on down the line for not only that child, but if you have a whole group, the community, the not the government, the country, is so significant. And lost opportunities of children who aren't cognitively developing appropriately. So I think a little bit of that, and although I'm very opposed to showing pictures that are just meant to elicit suffering, I do think sort of bringing us a little bit more into the feeling of what it is to be a malnourished child or malnourished pregnant woman. It's very compelling. And I think then I was a little bit taken aback. There was a picture of a man holding a really cute rabbit, and I kept thinking, are they going to eat that rabbit?
That's so
and I was like, oh, I don't like that so much. So that's sort of but I just wanted to, you know, and you may have vegetarians in your audience, and so just, you know, be aware of that.
I would have eaten the rabbit.
So I also think a lot when we talk about food in countries and growing gardens is, you know, there have been areas where food has been brought in, it's been to refugee camps and into internally displaced camps, but the food is just culturally not appropriate or so unappealing that it's not being eaten. And so just a little discussion on the cultural connection of this food to the community, and is this food people like, and I think would have been very helpful. I'd like to know how you're targeting the mothers for antenatal care if they're not seeking care.
I don't think it's that they're not seeking care, that they just don't see, there's too many barriers to getting there.
There's a fairly high rate of women going in for at least one antenatal care visit. The issue is that they go in their second trimester, and also they don't go in for 4 visits. They'll usually like go in for maybe 2, and a lot of women will think that like actual delivery is like their 4th ANC visit.
So I understand that.
Yeah.
I'm pushing you on this though, because how are you going to get them if they're not coming in until 4.5 months? How are you reaching the women at 1 month?
Sure, I can answer that. So we're choosing our champion moms that we mentioned before. We're choosing 2 per village.
Yeah.
So we're really using these mothers as outreach to kind of identify the pregnant mothers in the community and to assist with just the behavior change surrounding antenatal and postnatal care.
Okay. All right. So that's helpful. I think the next thing that I want to say is, are you engaging with traditional birth attendants at all?
They don't really use traditional birth attendants in this area,
Okay.
so it's not something to look into. Yeah.
That's great.
Yeah.
Good work doing that. So with community health workers, that's an area that I am very keen on and work with. And one of the issues with community health workers is that often there is training of community health workers, and it sounds great, and then they're sent out and they're not supervised, they're not equipped, and they're not paid. And so I think I'd like to hear a little bit more, because it sounds like they're going to be a very critical piece in this program. And so how are you planning on the sustainability?
So I can add on that. So first, they have expressed interest in receiving this training. They want to learn more about antenatal care and postnatal care. They have expressed that to us. And also, we will be providing them, once they complete the training, we'll be providing them with a pair of rain boots and an umbrella, as well as a notepad and a pen to take down the notes for the monitoring and evaluation. And the rain boots and the umbrellas is something that they had suggested due to the far distances that they're traveling and during the rating season.
Will anybody ever accompany them to see how they're doing?
Yeah, we had the field educators go out into the field anyway to kind of check the home gardens. So we're hoping to kind of piggyback on that. It won't be on every visit, but
I think it's just something to take
Yeah.
into consideration.
Yeah,
I mean,
absolutely.
all of us in our training as a doctor, I mean, I wasn't just sent to class and then I left and practiced medicine on my own. You know, I was supervised and monitored and have to do continuing medical education, and it's an ongoing, so the one-shot deal with community health workers, I do wanna just say, is not really a sustainable approach. So, to take that into consideration. I also just wanted to ask about, and I'm sorry, I was thinking about things when you were talking about incentives for the mothers. What were the incentives?
For the champion mothers or the pregnant mothers?
I don't remember which.
Okay, so
It's the
for
rabbit.
the
The rabbit. I was still stuck on
You
the
get the
rabbit.
rabbit.
I was still stuck on the rabbit.
Okay, so for the mothers that attend the first antenatal visit on time, they'll receive a seed packet.
Okay.
And if they attend all 4 antenatal care visits and the postnatal, they'll receive a chicken.
So, but then there was, you're going to stop the incentives.
Right.
And, so I just think you need to put that in perspective. I mean, there's lots of data on the incentive stuff, and the program stops, because really people are doing it for the incentives.
So we were gonna use the community mobilization within the meetings that we would do monthly to share knowledge about the what takes place during the PNC visit, get more awareness in the community, and try to build it up that way.
Yeah.
We're also incorporating behavior change models into the training of the community health workers and the champion mothers, and hoping that will
change the beliefs in
Yeah.
the community as well in regards to antenatal care and postnatal care.
So, and I will end with this. And you guys unfortunately got me, and I know a lot about community health workers, so. But you know, when you talk about behavior change, I mean, look at any of us in the room, it's not like somebody can say, you know, you shouldn't always get angry about that, and you say, oh, you're right, I won't ever again. You know, I mean, these behavior change is a lifelong process. And so, I really think about that when we start talking about these models in global health, that we're going to do behavior change, and we're gonna teach them that, and we did our course successfully, that these things are lifelong educational pieces, especially if you're dealing with deeply rooted belief systems. So take that into consideration as you look at these models and going forward, that they need ongoing repetition. So I thought you did a lovely job.
Thank you.
Okay, to start, 3 related questions, very uninformed questions. But remember, you're frequently speaking to people who know a lot less about your topic than you do. First, what are the drivers of malnutrition in Rwanda? Second, why is an education-based approach? In answering that, you would explain why an education-based approach works, or why does it work? And third, why are gardens important in a country to solve this problem in a country that by your numbers is 91% agricultural to begin with? So it would have been helpful, maybe you could answer it and then what drives malnutrition in Rwanda? It's 91% agricultural. Why is there malnutrition there among infants?
So a large issue is
And it's
crop.
silly, don't hesitate to say that's a silly question. You don't need
No,
to
it's not at
answer it.
all. So I think one of the main issues is crop diversity.
Right.
So a lot of these families grow crops, but only one kind.
Yeah.
So they don't get all the micronutrients that they need from the meals that aren't balanced.
Exactly, and you sort of buried the lead, as they say in journalism. Until we were 80% of the way through there, I'm coming in and I'm not knowing what the I'm not knowing what the driver of malnutrition is, and you're giving me detail on an education basis, and the importance of the prenatal and postnatal visits, and I'm not really sure whether what problem, I mean, I know what problem I'm solving, I just don't know what the driver of the problem is, and therefore you're ahead of me. If you would just lead with that, and just a little bit would have done a lot of good, then I can begin to input your solution and figure out, okay, that's an apt solution for that problem. Yeah, they're farmers, but they're raising one crop, and they don't understand. In fact, I think you also probably have to say a little more that the nature of the nutritional deficiencies are something that could be solved with fairly basic kitchen garden type solutions. It's not that the population in general, because of transportation, et cetera, can't get access to any of the following. It's an interesting topic in that it shows that sometimes very profound solutions to very important philanthropic or social impact issues, they don't have to be wildly creative or sexy. And I'm not diminishing your program here. I think it's extremely thoughtful. It's not flying Google balloons over places to bring the internet and therefore microfinance banking to. This is a fairly simple solution in some ways to a desperately important problem, but I need to know the problem up front or what's driving the problem, and then it's a very apt solution. So that was my principal, I guess, question, just to confirm that I understood what the driver was that we were trying to solve, or for.
So this is one area I do know. My company and I have created the world's largest hunger relief program. So in the last 7 years, we've donated about $500 million to solve hunger. And I was in Rwanda last year observing our work. So this one I know. First, to John's point, I'm a little concerned that gardens alone, frankly, don't provide enough nutrients enough nutrition to the individual diet and won't solve the problem. So my advice to you would be perhaps to partner up. In our case, we donate to the United Nations World Food Program, the largest humanitarian agency in the world. They have a very significant presence in Rwanda, and they're providing nutrient-enriched food, bars and other things, along with rice and grains and oils, and so they're helping people with their total nutrition, not just vegetables. So you might want to consider some kind of strategic alliance or partnership with some other organization in addition to the work that Gardens for Health is doing. So that would be one. The other is in Rwanda, unlike other areas, there isn't a water issue. They do have enough irrigation to in most other parts of, or many other parts of Africa, that is the primary issue. There's not enough water to grow the crops. Here there is. But I'm wondering, I don't know what these gardens are, so I'm not sure what nutrients you're actually providing. And so I think I'd want to know what that is. Could you tell us what vegetables and fruits and other things you're growing?
So it's avocado, sweet potato, and they do have beans, which would be rich in nutrients, and then they rotate on a seasonal basis. You get to choose from, I guess, how many different vegetables you need?
I am interested. There are 9 categories of vegetables, of different crops, 9 different categories, and they always get to choose from each category which type of crop they want to grow.
Okay, so a little bit more about how, I think it just underscores what John was saying, a little bit more about how these crops will actually provide enough nutrients in an individual's diet. I do think you zeroing in on the first 1,000 days was right. It's the right approach to prevent stunting, but I do think you could probably elaborate a little bit more on that for a donor. They'd want to know a little more detail behind that. Let me just see if there was. So I have to say, you threw a chicken in there at the last minute on us, and I'm not really sure where that came from, but if this is all about Gardens for Health, are they also doing livestock? Is that part of their program?
Yes.
Yeah.
So that probably should be a little bit elevated, because that, until the very end, I didn't know they got
Right.
seeds and a chicken. But I do think, so part of the solution is education. What Lynn said is critically important, that there has to be some incentive, like we do school feeding, and if a kid goes to school, they'll get a meal, and that's really their only square meal in the day. We do training for moms, both pre and antenatal training, and there has to be some incentive in there, otherwise they don't show up. And most of these moms, by the way, you didn't mention this, but they're not just watching a soap opera on TV, they're working, and they're working, they get up at 2 in the morning, and they don't stop until, well after the sun goes down, and then they repeat that cycle. They're the primary workforce here, believe it or not. So it's not, I don't think it's just transportation and childcare. It's also that they're in the fields toiling away. So somehow we have to solve for that problem as well, to get them to go to the centers. Those are more observations than they are questions, I'm sorry, but.
No, thank you.
Nice job.
Questions from the audience?
I was interested in you showed a garden plot.
Yes.
And then you also showed the plate.
Yes.
And I wondered if, my question is, that would be quite a lot of plot for the average Rwandan family, because one thing about Rwanda, it's the most densely populated, that and Burundi are the most densely populated parts of Africa. So people's plots are very, very small. So to get a big plot like that, a giant garden, I think would be unrealistic. The other thing is this plate, people eat out of they make a stew. And so the plate notion, and it's a problem here in the US too, that a lot of people, it was that graphic that really grabbed me. People don't eat from a plate, so that plate notion I don't think is perhaps as useful as it seems initially, because it all goes in, people are cooking on 3 stones in one single pot, and so I just think these two pieces here seem to me to be a little bit unrealistic given the actual conditions in Rwanda.
I've worked on your graphics too, I hate to say it, but I think you mentioned the plate, and I was struggling to remember the plate, so good for you for remembering it, but I think those are hard to read.
Yeah. Abby?
I really like the modules that show like supplemental feeding